Today we are talking about cardiovascular conditions. As you know, coronary artery disease is one of the main problems in our country. It's very important from an underwriting perspective and also from a claims perspective. Up to 50% of our serious illness claims relates to coronary artery disease. Coronary heart disease is also called ischemic heart disease or coronary artery disease. It all starts with plaque formation in the coronary arteries. The risk factors are genetic factors or family history, smoking, cholesterol, hypertension, diabetes, a sedentary lifestyle, and obesity. Here we have the process in pictures. It starts off as a fatty streak, even at a very young age, even in childhood. You can start with the fatty streaks, depending on how you live, what you eat, what your cholesterol is. Plaque will build up, and by the time that you're 30, there can be significant plaque protruding into the lumen of the artery. If the plaque ruptures, and various factors play a role there, smoking causes the plaque to be unstable, plaque ruptures, and platelets and red blood cells accumulate there and causes an obstruction in the lumen and occlusion. If this whole process happens in the heart, it's called a myocardial infarction. If it happens in the brain, it's a stroke or a cerebral infarction. If it happens in the lower limbs, it is called gangrene, or if it affects the aorta, an aneurysm will develop. This is the picture of an angiogram. This person has at least 3 significant obstructions in his coronary arteries. He would have received stents for those obstructions, and he is both a risk from an underwriting point of view and a possible claim on serious illness. The spectrum goes from an unstable angina right up to ST elevation myocardial infarction. This relates to the number of myocytes that gets killed or undergoes necrosis. The more cell damage, the more myocyte damage, the worse the outcome, and the worse the long-term prognosis. Coronary artery disease can present with chest pain and an exertion called angina. Women and diabetics can present with atypical symptoms, but normally one could expect that the client gets nauseous, sweats, complains of fatigue and dyspnea. ECG changes are common, the troponins in the blood test, angiograms and scans can all confirm the diagnosis. Interventions to treat this: angioplasty, where the obstruction is taken away, stents to keep the artery open. The new stents are all drug-eluting stents treating it, not just mechanically keeping the artery open. In severe cases, in diabetics, multi-vessel disease, coronary artery bypass grafts are done, and of course there's always medical treatment, and very important to control the risk factors. From an underwriting point of view, very important to look at all the risk factors, to take the history of a coronary artery disease event into account, the time period since the event, the number of events. Obviously, people with repeated heart attacks, repeated stents will have a worse outcome. The number of vessels affected are always important. More diffuse disease, poor outcome. Look at risk factor control. Also very important, the age at the time of the first event. Because of the relative risk that it's so much higher, and because the disease is relentlessly progressive. You can look at the outcome, the function, the New York Heart Association function, the METs achieved on an ECG, and the ejection fraction. And then there is CVS calculator in most of the reassurance manual that you can put in your risk factors, blood pressure, BMI, cholesterol, and so on, and you come up with a risk rating. Normally on our short medical, we get at least the blood pressure, we get BMI, we get urine tests, hopefully catching the diabetics, smoking, family history, and it's easy to add a cholesterol test. ECGs are problematic, they're difficult to do, very often false positive or false negative tests, and sometimes we just have to refer to a cardiologist to do a proper stress ECG, to do maybe an isotope scan, if it's warranted an angiogram or an echocardiogram to show us areas of hypokinesis and ejection fractions. ECG changes. Very importantly, it must be a proper, valid effort ECG. The formula for rates per minute is 200 minus the age of the client multiplied by 85%. A heart rate less than that means that it's not an adequate ECG. ST depression is a sign of ischemia. Q wave, sign of previous infarction. Non-progression of R waves in the chest leads can be a sign of a previous infarction. T wave can be a sign of ischemia. And a left bundle branch block can mask ischemic changes after exercise.